So we're going to start this meeting. It's an honor for myself and a pleasure to do this, to be the moderator, a co-moderator of this webinar, which is named The Transforming Scenery of Coronary Artery Disease and Its Implications. As my co-chairman, I have Professor Henrique Moraes, which you all know, apart from being a professor at the University of Federal University of Rio de Janeiro. He's also the scientific director of the Society of the Brazilian Society of Cardiovascular Surgery. And to debate, we have Professor Fernando Ribeiro Moraes Neto, who is a dear friend, and apart from that, he's also the president of the Cardiology Society of Pernambuco, and is also a dedicated cardiovascular surgeon and a professor of the University in Pernambuco. The three of us will be at the end debating and asking questions for all the faculty. The faculty is a well-known faculty, and Professor Henrique Moraes and I will be presenting each one of you at the time. I just want to put a point. This webinar was taken up for a discussion between people who are engaged in CABG, and we invited Dr. Greg Stone, which is one of the principal investigators in many studies of PCI, and he personally refused our invitation to be here. I don't know why, because I didn't tell him who was in the faculty at this webinar, but he told me that we published a paper that was published in the European Journal of Cardiovascular Surgery, which the first author was Walter Gomes, and as I was the senior author, he was disgusted with my points of view. So I'm sorry, but I have to declare my interests and my bias over here. I wanted to have him here. He refused once more to debate with the cardiac surgeons his point of view, but that's his prerogative, and we have to accept that. And we'll start with the next presentation, which will be by Victor Dayan. He's going to speak about the tainted scenario of scientific evidence-making practice. Victor is a dear friend from the last year. I met him. He's a fantastic guy with a great innovation in spirit. And he's president nowadays of the Uruguayan Society of Cardiology. Just let me tell you that the Cardiology Society over in Uruguay is together with the cardiovascular surgeons. And he's a professor in cardiac surgery of the University of the Republic of Uruguay. Victor, it's great to have you here. You're the guy and the inspiration for LACES, which is the Latin American Association of Cardio and Endovascular Surgery. And I'm very proud to present you and for you to be here.
Thank you very much, Rui. So let me start by thanking Rui and Walter Gomes and the rest of the society, the Brazilian Society of Cardiovascular Surgery, for the privilege of being surrounded by so many prestigious cardiac surgeons from the region and internationally. In this case, Dr. David Taggart. It is a pleasure for me. So I will be presenting the tainted scenario of scientific evidence-making practice. So in order to start, first, let me just tell a little story. It is a real story. I don't know how many of you know Genentech. Genentech is a medical company which is based in the San Francisco Bay Area. In the 13th of November of 1987, the sky of San Francisco was illuminated by fireworks that exploded in the air, and for the first time in history, during 10 minutes, the air traffic was halted in the San Francisco area. And the reason for that was that the FDA had approved TPA, which is manufactured by Genentech for the treatment of acute myocardial infarction. If we see a little bit of background regarding this spectacular moment, in the 1980s, the NIH developed a program focused on investigation of reperfusion for acute myocardial infarction. This is a program that was called the TEAM Study Group, which was headed by Dr. Eugene Braunwald. This program and this group had as main objective to investigate and to progress in the investigation of TPA for the perfusion of acute myocardial infarction. As a matter of fact, in 1955, they published in the New England Journal of Medicine a randomized controlled trial in which they showed that the TPA was almost twice as effective as intravenous streptokinase, opening occluded infarct-related coronary arteries. This was a surrogate marker, and they weren't able to show benefit in strong clinical outcomes. Therefore, at the other side of the ocean, in Europe, they didn't buy that finding very much, so they started 2 big randomized controlled trials. One of those was the GC2 trial, which recruited over 12,000 patients, in which they found that TPI and streptokinase were equally effective. And then the ISIS-3 trial, which recruited over 40,000 patients, in which they found no differences between streptokinase and TPA. These results were not very convincing for Dr. Eugene Bráulio, who, as a matter of fact, recruited Eric Topol, which at that time held options for 6,000 shares of Genentech, which, if you recall, Genentech was the producer of TPA at that time. So Eric Topol headed this important trial, which is the GUSTO trial, in which they compare 4 different thrombolytic agents. One of those was the TPA for acute myocardial infarction. This was a trial that was supported and sponsored by Genentech. And as a matter of fact, the conclusion is not very surprising. And the conclusion was that TPA, compared with the other 3 thrombolytics, showed a survival benefit compared with them. In the Data and Safety Monitoring Board, we were able to find Dr. Eugene Bráulio, which was the chairman of that trial. So this confrontation between Europe and North America is not new. So in the 1980s, this was not only stayed at the scientific arena, but transcended into the public arena, and data and this confrontation occupied the primetime news of the program 2020 from ABC. So this is not the first time that problems between cardiologists among themselves or between cardiologists and surgeons get into the primetime news. So what do we need from evidence to decide the best treatment for our patients? Evaluated patients need to be representative of real-life patients. Patients in trials need to be representative of the patient that we see every day. Outcomes need to reflect what really matters to patients. Evaluations need to be objective and performed by unbiased investigators, and databases should be open. Now, data should reflect real-life patients. What do we mean by this? We mean that the patient conditions in these trials should mimic those in real-life patients, on the patients that we see on a daily practice. The treatment procedures in those trials should be similar or the same that the ones that we use in our real life in order to use data from those trials. If we are going to use data from those trials, we need to use the same procedures that were used in those trials. And another thing which is very important is that post-procedure medical treatment adherence and control needs to be similar to what we see in the trials in our daily practice. Now, this is a very interesting editorial, which is based on some of the pillars of Archie Cochrane, in which trials which evaluate treatments mainly focus on 3 things. They can evaluate on the efficacy of a treatment. In that sense, they will be evaluating if it can work, and that will be done and evaluated in ideal circumstances, which are clinical trials. Other investigations might evaluate the treatment if it's effective. Does it work? And in that case, they will be evaluating in real life practice. As a treatment can be efficacious because it works in perfect scenarios, in an ideal scenario like a clinical trial, but it might not be effective. That's what we see with clinical registries. That's why it's so important to know and to get the data from registries. And finally, efficiency. Is it worth that treatment compared with the clinical outcome that we see for that treatment? Now, regarding patient conditions, it's very important to see if a trial considers the patients, the recruitment of the patients of those in clinical trials regarding the percent of patients that were recruited, what percentage of those really get into the trial. That's a very important percentage in order to get the external validity of those trials and to know how much that data applies to our real practice. And for example, since we have David Taggart here, let's focus on trials which focus on PCI versus CABG for left main. This is the trial from Bráulio and collaborators published in 2011, in which they evaluated 430 patients with left main coronary artery disease, but only included 47% of those patients. This is the syntax trial in which they evaluated 4,337 patients, but they only included 41.5% of those patients. And then this is the pre-combat trial, in which they evaluated 1,454 patients with left main disease, but they only included 40% of those patients. Nonetheless, guidelines are written for 100% of patients with left main disease. So it's more frequent. The probability is higher that a patient that we see in our daily practice with left main disease, the probability is much higher that that patient would not have been included in one of these trials which have been included in that trial. Therefore, outcomes for those trials generally do not apply for our daily practice patients with left main disease. Now, regarding treatment procedures, generally, treatment procedures in patients for coronary artery bypass versus PCI are really reflect what we do in our real life scenarios, taking into consideration global numbers. Generally, in the PCI, in the CABG arm, generally the percentage of patients who get Lima to LAD or who get bilateral internal mammary artery graft or radial artery or off pump, on pump is generally similar to global data. And regarding PCI data, generally the data is similar, the procedures that are performed are similar to what is done in real life, except for the use of IVUS in patients with left main disease. In trials which compare, which include patients with left main disease, over 70% of those patients use IVUS. In our country and in the region, the use of IVUS for left main disease is extremely low. There's not the availability of that technology. Therefore, we should not use data from that trials if we are not going to use the technology that are used in those trials. And then post-procedure medical treatment adherence and control is extremely important. Why is that? This is how I see patients in randomized controlled trials. They are like lab rats inside a cage in which the investigator controls everything that happens to them. These are patients in real life in which investigators do not control what goes on with them and what the patients decide to do. Now, what was the treatment compliance for medical treatment in Excel trial after 3 years? For aspirin, statins, and beta blockers, patients in the PCI and CABG arm, in both of those cases for all these medications, patients had an adherence of over 90%. Now, what happens in real life? In real life, this is a big meta-analysis which pulled data from a lot of registries, which showed that patients with cardiovascular disease had an adherence which was about 50 and 60% to the medical treatment. And if we consider secondary prevention, which includes patients with after undergoing PCI or CABG, for aspirin, adherence was 65%. For statins, it was 76%, and for beta blockers, it was 62%. Now, why is this important? It's important because, as Kurlansky has shown, patients who do not adhere to medical treatment and who undergo PCI have worse long-term outcomes compared with CABG. And as they show in their conclusion, PCI and CABG may not differ globally in this study. However, among non-adherent patients, CABG affords better major adverse cardiac event-free survival. And this is something that is not shown in guidelines. Then outcomes need to reflect what really matters to patients. And here we come with the issue with definitions. We have been a witness to, in the last couple of months, to a lot of arguments and discussion regarding the best definition for procedural MI and whether procedural MI or spontaneous MI should be part of the composite primary outcomes in trials which compare CABG with PCI. Regarding the left main trials, from the 5 left main trials that are up to date, only EXCEL is the only trial which did not include electrocardiographic changes as part of the definition of procedural MI. And when the investigators were confronted with this, the investigator, what they answered was that since patients after CABG have a lot of bandages, it's extremely difficult for them to do electrocardiographic after CABG. Let me tell you that I live in a third world country and I get all my patients after CABG an electrocardiogram, and I think it's totally unethical not to do an electrocardiogram after CABG every 24 hours. Now, we already know that the incidence of procedural MI varies according to the definition which we use for defining procedural MI. And as a matter of fact, perhaps Dr. David Taggart will expand on this. If we use the universal definition for procedural MI in the EXCEL trial, the primary composite outcome would have been in favor of CABG significantly. Now, when I confronted Dr. Stone in public media, in Twitter, as a matter of fact, which he really likes to discuss this in this public media, and I said to him that I confronted him regarding his definition for procedural MI, saying that he tailored this definition in order to benefit his own outcome, and therefore he was being judge and jury. He really didn't like that confrontation. He said I lost all credibility. But the best of all is that he compared me with Dr. Taggart, which is quite an honor for me. And then he blocked me, of course. So, since procedural MI is such something that generates, so people do not really get into a decision regarding the best definition, why don't we remove this outcome and only only include spontaneous MI? Perhaps this is an issue that we should discuss at the end of this webinar. I know this is very interesting. This is a recent meta-analysis that was published by Dr. Stone and Sripal Bangalore regarding patients with stable ischemic heart disease, in which they compared revascularization versus optimal medical treatment. In the conclusions of this meta-analysis was after the publication of the ISCHEMIA trial. In the conclusions, they say that routine revascularization was not associated with improved survival, but was associated with a lower risk of non-procedural MI. In this meta-analysis, Dr. Greg Stone considered that a lower risk of non-procedural MI was really important in order to be included in the conclusions. As a matter of fact, in Twitter, he stressed that point, saying that even though there was no difference in stroke, heart failure, or all-cause death, the net results favored revascularization in stable ischemic heart disease, and he stressed the importance of the lower non-procedural MI. So, sorry, excuse me, this is something that really is, I can't get it very nicely, since Dr. Stone specifically used these same arguments against EXCEL when CABG showed exactly the same benefit as revascularization showed in this meta-analysis. And this does not stand there. As a matter of fact, he published another meta-analysis. As a matter of fact, he published a lot of meta-analysis recently, in which he compared PCI versus CABG for left main coronary artery disease, and he published, this was a fast-track publication in the European Heart Journal, in which, if you look quite buried into the results section, they state that procedural MI was more common after PCI. As a matter of fact, in this case, it apparently is what this issue is not so important, since the graph and the results figure concerning this was buried into the supplementary material. And not only that, but that didn't even get into the conclusion, in which the conclusion was that there was no difference in cardiac death, stroke, or MI, which is false, since non-procedural MI was more common after PCI. In this case, apparently, non-procedural MI was not so important for the investigators of this meta-analysis as in the previous meta-analysis. So, evaluation needs to be unbiased. When we say unbiased, we mean that the investigation needs to be as separated as possible from the sponsors of the trial, and the sponsors of the trial need to be as isolated as possible in the analysis of the trial. In this case, in the Syntax trial, which was sponsored by Boston Scientific, we see that Boston Scientific was part of the data analysis of this trial. In the case of the pre-combat trial, in which was supported by the Cardiovascular Research Foundation, we see that the first author, second author, and senior author were also part of the Cardiovascular Research Foundation Board of Trustees. As a matter of fact, the senior author was the founder and chairman of the Cardiovascular Research Foundation. And in the Excel trial, which is a study which was sponsored by Abbott, we see that Abbott relied on the Cardiovascular Research Foundation for the data analysis, for the clinical events committee, and we already know that in the Cardiovascular Research Foundation, we have as faculty Dr. Greg Stone. Now, why did Abbott assign Cardiovascular Research Foundation for the analysis and so many roles in the Excel trial? If you go to the financial reporting, which is quite publicly available in the website, we see that a lot of money was transferred from Abbott to Cardiovascular Research Foundation as donations during the lapse of the Excel trial. During 2016, over $1 million was transferred from Abbott to Cardiovascular Research Foundation, and in 2017 and 18, over $2 million were transferred to the foundation, which evaluated great part of the Excel trial. Now, in order to end my presentation, I think it's very nice to end it with this quote from Upton Sinclair, which is a very important political activist, which I think it wraps up the issue regarding industry finance trials and how important and difficult it is to bypass that bias. It's difficult to get a man to understand something when his salary depends upon his not understanding. Thank you very much.
Thank you very much, Victor, for your nice lecture. I just want to stand that there's people from the Lacey Society over here attending this meeting. As also, I'd like to stand for two names that are great names in cardiac surgery. I would like to point that from this meeting, Dr. Thomas Salerno from Miami Jackson is attending it, and also Dr. Manuel Antunes from Portugal is attending also this meeting. I'll pass the word to Professor Henrique Moura.
Very nice presentation, Dr. Dayan. Very, very nice and instructive. Well, I thank the society here as co-chairman of this interesting webinar. And with much ado, I would like to invite Dr. Bráulio Filho, who is associate professor in cardiology at the Federal University of São Paulo, e a Escola Paulista de Medicina. And he's going to talk to us about managing coronary artery disease after ischemia. Dr. Bráulio.
Initially, I would like to thank you for that kind of invitation. It's a great honor for me to participate in that kind of panel. I begin to say that ISCHEMIA Trial is not, when I say a thunderbolt in a blue sky in the cardiological field. For a long time, I believe that since the end of the 80s, we have discussed what the better approach in terms of the stage ischemic heart disease. There's a lot of argument in favor of more invasive approach. More recently, the clinical approach gained a little steam in terms of development. I'm not going deep in terms of each of that study, because it depends on all the quality of that trial and the movement around how to do that. What, in my view, what is important is what is happening in the clinical practice, how the patient and medical doctor is doing in daily practice. Unfortunately, I believe that independent of kind of quality of clinical data that you have and to support one another conduct, I think you have a lot of controversy in terms of what the better treatment for the patient, how to bring to the clinical, to the patient what the best result of what you know about some subject. And that Untitled registry shows what happened in the general practice. Because with more than 370 patients and follow up more than 1 decade, the majority of patients with stable ischemic heart disease is going to revascularization in the majority of the cases. And when I think what is worse is the publication of that result support the idea that they what I'm trying to say is that some study that support a more invasive approach has a lot of bias, and mainly when they are supporting big sample like big data, it don't care. It don't care. It's not able to guarantee that kind of practice is supporting and scientific evidence. What most you can say is that is the daily practice. Is that the way the science is going on in the medical field? So I think the ischemia came up in a very opportunistic moment, very, very important moment, because you need a study that could face all the criticism that some studies received along the time, like body due to Coronary Artery and so on. The ISCHEMIA trial faced a very important issue for our medical clinical as me, and I think for you two great surgeons in that field. Any stable patient with at least moderate ischemia, what the best approach? Is invasive or more conservative approach? And take into consideration, wow, now I can't go for, now I could move, okay. And take the all criticism and other clinical trial, I believe that the design was a quite good design because they select only mainly stable patient with ischemic coronary disease, and all that patient was evaluated by image ischemic stress test, and only that patient with had moderate to severe ischemic stress was sent to do a CT scan. The CT scan in that situation was very important because they guarantee the presence of the obstructive coronary disease and rule out patient with left stem heart disease. Only then the patient was randomized, because before then, all the studies randomized immediately. In the beginning of the select the patient, and sometimes you could have selection bias because you could select patient for one arm and not for another because you know the coronary of that patient. And so we have two arms. The invasive strategy arm receive the same kind of optimal treatment, but all patients, and within 30 days, were sent to the cath lab. The conservative arm, by the opposite, received only the optimal medical trial and was sent to the cath lab only when the medical treatment failed. Another important aspect of that ischemic trial is the primary endpoint. The primary endpoint initially was fundamentally cardiovascular death and myocardial infarct, but because of the low rate of recruitment and because of the low aggregate event in that during that time, the author of the study amplified or expanded the primary endpoint with some other component like heart failure and resuscitated cardiac arrest. The major secondary point that was primarily the endpoint because was cardiovascular death, myocardial infarct, and quality of life related with the angina pectoris. In that regard, the ISCHEMIA trial select 5,179 patients. The initial objective was to select 80,000 patients. That has a consequence to decrease the power of the study. Not so much, because I think the power of the study is around 80%. That patient was followed for 3.3 years. And in my view, the characteristics of that sample, it's very important because they were selecting a high-risk patient, a high-risk group of patients. And that was supported inclusively by the stress test modality. The majority, 75%, did the image stress test. And the quality of, that quality of the stress test shows that at least 80% of the patients had moderate to severe ischemia. So it's a very important group with a high risk about all kind of consideration. During the follow-up, 95% of the patient in the basic group performed the catheterization, and 80% received some form of the revascularization treatment. 76% was PCI, the treatment choice. In the conservative group, 28% in the follow-up had started by the catheterization, and 23% receiving or almost 80% receiving PCI. The result was interesting, and that was the importance of the ISCHEMIA trial. And because the results show there is no difference between any kind of between the two approaches, no difference at all. And for disappointment of the author, the line that represents the cumulative incidence cross. That means that I can do Cox proportional analysis because the risk of the event is not constant along the time. So I can't say anything more. But despite the fact the author analyzed the event, and the major important component of that curve was cardiovascular death and myocarditis, and divide the analysis in two moments. The first moment, when they say the invasive treatment generate more myocardial infarction, but that it was compensated later on by the increase of spontaneous kind of myocardial infarction in the conservative group. And then you have the problem with the periprocedural procedure. I can talk a little bit. But what the advantage to say that, okay, I have a nice way to induce myocardial infarction, but that is compensating a long time. But what the reason to make that kind of interpretation? Because there is no influence in the cardiovascular death. So they come up with the idea that because the patient had myocardial infarction in the first 6 months, in the long, they get better quality of life immediately. And that it looks like sustainable. I think that kind of reason very, very weird in my viewpoint. And I'm going to talk a little bit just about that. In the end, in my view, the major and important conclusion of that trial is that there is no difference in invasive strategy in relation to comparative strategy in patients when you have a stable condition. For example, LVV, you don't have dysfunction, left ventricular dysfunction. That I think is the major. There is no any option, any alternative to choose one or not has to be individualized, has to be tailored for each patient. You don't have a solid rule to say that invasive treatment is better than conservative treatment, by the way. Of course, that ISCHEMIA trial, like all other clinical trials, has a lot of strengths and limitations. I'm not going to tell a lot about that because you know. I think the one aspect that has received less emphasis is when you take into consideration that I improve very fast the quality of life of the patient when I send that kind of patient to the invasive group. I don't buy that because the questionnaire, that kind of evaluation is done through questionnaire, the Seattle Angina questionnaire. And there is a subjective interpretation when you say the patient improve or not, mainly because the patient, the study is unblinded trial. Patient and doctor know who's taking invasive procedure. And you know from the Orbit trial that is important viewpoint in terms considering that 2/3 of that patient receive PCI, and you know that at least during the evolution, they have much more intervention, 3 more times than the conservative group in terms of the side effect of the PCI. Despite that, we have recently a meta-analysis that combine all that important clinical trial in that area, including the ischemic trial. And I can tell that now I am much more confident in some viewpoints. For example, consider that the majority of that trial, the revascularization procedure was PCI. I can tell you that PCI don't decrease cardiovascular mortality, mainly in that kind of patient. Absolutely, we can say, and could say still more. PCI don't diminish it, don't decrease the chance of myocardial infarction. I think that is one point that has become very clear recently. Besides this, in the ischemia trial, despite all the effort of to treat the patient the best medical therapy that you have, that's now, and that is available for everyone, only 41% of the patient get a good level of the optimal medical treatment. So you have a lot of room to involve, to improve the compliance and the adherence of the patient to a good medical treatment. Of course, that surgeon, that stent is still involved, and the technology is always the next corner. Okay, but improving the quality of medical treatment is already there. It's already there. You don't need to do anything new. It's already there. And there is important room to improve. So in my viewpoint, in this scenario of stable ischemic heart disease, if patients don't have too much angina, don't have refractory angina, the conservative treatment has to be the initial approach for that kind of patient. Only when that kind of treatment don't respond adequate, you can move it to invasive form of treatment. Could be cabbages, could be PCI. Of course, I'd like to finish that brief exposition, say that ischemia is not a perfect trial, but I think they fulfill an important role. They clarify some important role for our clinical at Dayan. For example, the automatic treatment works, and I think that they could still do much better than they have done if you could increase the compliance of the patient to that kind of a treatment. And I think you got another important message, include for my clinical practice. If I had to evaluate the patient, probably image stress test is not the better way, because there is no influence in terms of the result in reduction of myocardial infarction or expanding the expectancy life of that patient. Maybe the CT scan will be better way to maneuver this patient. That's my viewpoint, and I hope we could open up for discussion. I could detail some analysis that I have in terms of some statistical approach of that study. Thank you for your attention, and excuse for the problem at the beginning of that presentation.
Thank you, Dr. Bráulio, for your presentation. Your take-home message would be very good to take home. And now I invite Professor Walter Gomes, who is a professor of surgery at the Federal University of São Paulo, the Escola Paulista de Medicina. He's going to talk for us on when and how bilateral RTA grafting is a winning strategy. Is it always, Dr. Walter?
First of all, thank you very much. Congratulate the Brazilian Society and the organizer for this meeting. A privilege to be here with so distinguished cardiovascular surgeon. I'll start my presentation talking a little bit about the ISCHEMIA trial, which was made easier because of the Bráulio's talk, which was my predecessor. The ISCHEMIA trial, in fact, it's a seminal work and has the potential to change all the landscape of the treatment of coronary artery disease. In fact, the concept of a flow-limited stenosis coronary artery could lead to the so-called chronic myocardial ischemia. It was supposed to be the causal factor of death in coronary artery disease. So, the ischemia trial, in fact, they have killed the myth of the chronic ischemia in determining prognosis in patients with coronary artery disease, and just reinforcing the change, the findings of the earlier trials like the Courage, the Berry 2D, and the Mass 2. In fact, what we know from all the pathophysiology of the coronary artery disease, and also stemming from these findings, that the stable plaque, that plaque we see in the angiogram, the plaque which is blocking the lumen of the coronary artery, blocking 60, 70, 80%, and used to scare cardiologists and cardiovascular surgeons alike. This plaque, which is the stable plaque, is not the cause of the myocardial infarction and the death of the patient. What's the cause? Is the rupture of the unstable plaque. And the rupture of the unstable plaque leads to an acute coronary syndrome and an acute myocardial infarction, which is the cause of death in coronary artery disease. And you can see the cause is the rupture of an unstable plaque, which is located very far away from the stable plaque. Usually some irregularities in the wall of the coronary artery, and located upstream and downstream the site of the stable plaque. That's the rupture of this plaque, this unstable plaque. That's the cause for the myocardial infarction. And that explains the difference in outcomes between the revascularization strategies, which is a PCI and CABG. Why PCI is not able to change the rates of myocardial infarction and death compared to medical treatment in advanced coronary artery disease? Because PCI just treat the stable lesion, which is not the cause, it's not responsible for the event of myocardial infarction and death, because the many unstable plaques located upstream and downstream the lesion that cause all the events leading to the death of the patient. On the other way, CABG, by placing the graft far away, distal to the site of the stenosis, is treating not only the stenotic lesion in the coronary artery disease, but all the potential unstable plaque which can rupture and cause a myocardial infarction. So CABG, by doing this graft distal of all of the lesions, can prevent myocardial infarction. And it can take us to the long-term survival after CABG is associated to the ability of the graft to remain patent longer. That's the case for bilateral internal thoracic artery grafting. We can see from this explanation, it's reflected in the trials we were just published, like the syntax, the long-term follow-up of the syntax, 10 years, the 10 years follow-up of the syntax, which investigated patients with coronary artery disease and pre-vessel involvement. You see how CABG is able to spare the life of patients over the long term. You see the curves for both treatments, they are diverging over time, showing the capacity, the ability of CABG to increase survival. The same for the Freedom trial, It's the long-term follow-up of 7.5 years follow-up. In patients with diabetes, the CABG is able to prevent myocardial infarction and improve survival in the long term. You see how the curves are separating over time from one another. The same for the stitch trial, where CABG is more efficient than medical treatment in treating patients with low ejection fraction. You see the 10 years follow-up of the stitch trial showing the ability, showing how CABG can improve survival over the long term. See how the curves are diverging each other. Even in the Edição trial at 5 years follow-up, the so ill-fated and cursed Edição trial, see how much is the difference in long-term survival with CABG and PCI, with statistically significant difference in survival at 5 years follow-up between the two strategies. And the survival advantage of CABG, it's given, it's granted by the anastomose of the memory to the LAD. And how can we do it better? The way to do it better is a beta grafting, because as I said, the ability to improve survival and decrease the risk of long-term myocardial infarction is given by a long-term patent grafting, a grafting working for a long time after the operation. And that's what the internal thoracic artery grafting is able to do. Regarding that, the ART trial was a seminal trial studying this type of patients. Despite the fact of not showing any difference in long-term mortality and the composite endpoint, we see that over the long term, in the 10 years follow-up, how the curves are separating from each other, like in the other trials I show you, the same way. When we see the composite outcomes of death, myocardial infarction, and stroke at 10 years, the bilateral ITA is better than the single ITA, although not reaching statistically significance at this time. But if you go over all the primary and isolate outcomes, if you see the primary outcome, death from any cause, numerically, all the figures are better with bilateral graft compared to the single graft cohort. The same for the composite endpoint of death, myocardial infarction, and stroke. Numerically, the numbers are much better for the bilateral, although not reaching statistically significance, but it's quite marginal. Even the rate of myocardial infarction over the long term is lower with the bilateral grafting, and there is no difference. And even stroke is lower with bilateral grafting, showing the potential of bilateral internal thoracic artery grafting to provide better outcomes on the long term, I would say, over 10 years follow-up. That was demonstrated by meta-analysis. That's a meta-analysis published in the Heart in 2017, including nearly 9,000 patients. And the conclusion is a long-term cardiac mortality and myocardial infarction is better with the bilateral internal memory artery grafting. And even in diabetic patients, that's the finding, that the bilateral memory can improve survival in patients with diabetes. Which is very consensual, because the the atherosclerotic disease in the diabetic patients, it's widespread in the coronary artery. And that makes more and more unstable plaques that can rupture and lead to a myocardial infarction. So a graft that can remain patent over the long term can avoid a myocardial infarction, which is the cause of death in coronary artery disease, and then this patient can live longer, even in diabetes. What's the problem with bilateral grafting? It's the external one complication. That's the drawback, the Achilles heel of this technique. And that's what we have to tackle, improving our operative technique. How can we do so, improve our operative technique in order to reduce this complication, which is external complication? All the evidence points to the skeletonization of the internal thoracic artery. It can lead to a less complication, and the results, even in patients with diabetes, the results are compared between single and bilateral memory grafting if we use the skeletonized technique. So that's the step ahead in managing this type of patient, making possible to revascularize this patient with using two memories and without the risk of the surplus in the external complication. One important point, and it was raised by the ART, the outcomes using bilateral internal thoracic artery grafting is related to the surgeon expertise and experience. So surgeons performing more and more bilateral grafting have better results than the less experienced surgeon. So completely related to the experience of the surgeon and also of the operative team. What's the problem with CABG? As I just showed, CABG is the best therapy for treating patients with advanced coronary artery disease. That's the only method providing decreasing the risk of myocardial infarction, and also providing better survival over the long term. But the problem with CABG is the increase the risk of stroke. In fact, it's a slight increase of the risk of stroke, but it's apparent, and it come up in every meta-analysis we see about comparing PCI and CABG. How we can prevent this complication? And the meta-analysis from Zhao and also co-authored by Dr. Taggart is clearly shown that if we cannot avoid manipulation of the ascending aorta, we can reduce the rate of the stroke and improve the other outcomes like mortality over the long term. So avoiding manipulation of the ascending aorta, which is the source of embolic materials to the brain, we can decrease the risk of the stroke. So, and what's the patient in the greatest risk of stroke during on-pump CABG operation? This patient, they have advanced age patient with aortic atheromatous disease, patient with diabetes, females, hypertension, peripheral vascular disease, previous neurological injury, carotid stenosis, and also the use of cardiopulmonary bypass. So by avoiding manipulation of the ascending aorta during the operation, we can bring down this risk compared or better than when compared with PCI. That's some takes from that's a take of operation where we are dissecting the memory using the skeletonized technique. You see, we use the tip of the diatheria to free the memory from the fascia, go all the way up and down. Fascia, now the artery is free from the fascia. Now you see the memory dissect in the skeletonized way. And then that's the dissection of the right memory. The same way we are liberating the memory from the fascia. Just have in mind that the anatomy of the right memory is slightly different from the left. That's the right memory, which is completely dissect in the skeletonized fascia. And then using both memories in an off-pump surgery, we're using an aortic technique. You see the left memory anastomosis to the LAD with a sequential to the diagonal. The right memory was used as a free graft, the bottom end at the marginal, the top end as a wide graft attached to the left memory. So three grafts using the two memories. The same, the left memory attached to the LAD, the right memory used as a free graft to the marginal in a Y fashion with the left memory. And then that's why we are using the right memory in a in situ fashion, coming through the transverse sinus to the lateral wall, anastomosis to the marginal. So that's the final view of the anastomosis. So we can use both memories, a bilateral internal thoracic artery grafting without touching the aorta with the aortic technique in off-pump surgery. Thank you very much.
Thank you very much, Dr. Walter Gomes, for your presentation. Now I have the pleasure and the honor to present a great friend of Brazilian cardiovascular surgeons, Mr. David Taggart. Mr. David Taggart is professor of cardiovascular surgery at the University of Oxford, and he has been one of the cardiovascular surgeons in the world that has mostly defended practice of CABG, and even at a personal loss, I could say so. But he's a fantastic guy, and he's been in Brazil for so many times, and we miss you very much to come over here. But at least we can see you through the screen and to hear you and learn from you. Thank you very much, David.
Very good evening, and good evening to all my friends in Brazil. Believe me, I miss Brazil very much as well. I would like to thank the Brazilian Society, and in particular, for this invitation. And what I'm going to largely do tonight is talk about left mainstem disease with the perspective of the EXCEL trial. I would also point out that I have to apologize that I'm going to talk in English, but I cannot, unfortunately, do it any other way. I do have some conflicts of interest. One is clinically as a cardiac surgeon. One is I was the chairman of the surgical committee of the EXCEL trial, but withdrew from the final New England Journal of Medicine publication, and I'll explain why that was. And I do have some commercial interests, but none of them relevant to this presentation. I would draw your attention to this paper by Walter and Hui and Dr. Jetin, published on the 1st of July online in the European Journal of Cardiothoracic Surgery, that really addressed in great detail many of the limitations of the EXCEL trial. And what I'm going to say before I turn to the EXCEL trial is to say that whenever we're looking at CABG versus PCI data, it's always very important that if you want to get a true picture of the real benefits of cabbage, you need to understand the way data has been presented. Dr. Dayan referred to some of this, but for example, most trial patients are very highly selected and have less severe coronary artery disease. So they underestimate the real benefits of cabbage that we would see in patients with more severe disease in routine clinical practice. Duration of follow-up must be a minimum of 5 years, and ideally, as in the ART trial, it should be 10 years, because in most trials of PCI versus cabbage, increasing length of follow-up shows an increasing benefit of cabbage, as Dr. Gomes has just shown. Also referred to by Dr. Dayan, if you look at all the trials of PCI versus cabbage, the use of guideline-directed medical therapy is always substantially inferior in cabbage patients. So although the cabbage patients actually do better than PCI, if the cabbage patients had a better medical therapy, then those differences would have been even greater. And the next thing I would say is a recommendation. If you're ever asked to review a paper or you're reading it for personal interest, always look at the data and results yourself before you ever read the text. Because when the text is written by the cardiologist, it will often have a very pro-PCI bias, which doesn't actually reflect what the data often shows of the superiority of cabbage for survival, myocardial infarction, and repeat revascularization. To turn to left main, more than a decade ago, we published this paper looking at all the evidence for treatment of left main by cabbage or either PCI, and we concluded that cabbage was the best therapy. And that was based on the fact that up to 90% of left main lesions are distal bifurcation and have a high risk of restenosis, and that up to 90% of patients have multivessel coronary disease where cabbage already offers a survival benefit. Now, if you look at what is the clinical reality of cabbage in today's practice, let's quickly look at multivessel disease without left main, because cabbage is a clear winner for every level of syntax score, and especially in patients with diabetes. If you look at patients with left main disease, the first thing we have to appreciate is that very few patients with left main disease have isolated disease. It's less than 5% of patients. And the vast majority of patients today, as we showed in 2008, still have multivessel disease. So remember that in contemporary practice, this is a bit of an artificial separation between multivessel and left main disease, because the clinical reality is most cabbage patients have multivessel disease with or without left main. So what prompted the Excel trial was a sub-study of the syntax trial of 705 patients with left main disease. And what they showed, the investigators at 5 years, was there was a clear discrepancy what happened to patients with left main with syntax scores below and above 32. And above 32, there was an accelerating divergence of MACE curves in favor of cabbage. And this is what was used to define the patients entered into the Excel trial. And it begs the question, why did patients not do so well with cabbage with lower syntax scores in left main? And that's probably because these patients did not have additional significant coronary artery disease, so there was too much competitive flow for bypass grafts. So this is a paper from the New England Journal in 2019, the 5-year outcomes of Excel. And again, I would make a few key points about the paper is that first, these were selected patients with left main disease. It was not all comer. It was patients with syntax scores below 33. The trial recruited 1,905 patients, but it was actually stopped early because the initial recruitment plan had been 2,600 patients. The next thing to consider is that these patients were relatively young. They had a mean age of 66, so would have an anticipated life expectancy of 15 to 20 years. And the primary outcome was a composite of death, MI, and stroke, but not repeat revascularization. And 36 of the 37 authors remained on the paper, but I withdrew my authorship. So what was the controversy over the EXCEL trial? Well, it led to 3 major societies of cardiothoracic surgery, EACTS, AATS, and STS, all demanding an independent reanalysis of the results. Both CRF, who conducted the trial, and the New England Journal of Medicine have both announced, respectively, investigations into the conduct and reporting of EXCEL, but neither of these reports have been made available to date. And the BBC Newsnight programme in the UK produced 2 reports regarding the failure of EXCEL to report myocardial infarction data and the concerns that have been raised by the Data Safety Monitoring Board. So there are 4 major concerns with the EXCEL 5-year analysis. The first is change statistical analysis, non-inferiority design to superiority at 5 years, and I'll show you the implications of that. The second major concern was the interpretation of the mortality data. Thirdly, persistent failure to publish protocol-specified myocardial infarction data, and finally, failure to share trial data. So what are the important facts about the EXCEL trial? Well, it is the largest and most definitive trial of PCI versus CABG in left main disease. So the principal investigators, the participating doctors, and all the patients who took part deserve enormous credit for driving this pivotal and seminal landmark paper. I was the chairman of the surgical committee of the EXCEL trial during its design and recruitment phase. My centre in Oxford was the second largest recruiter of patients to the EXCEL trial worldwide. We recruited 100 patients, and I think that shows a testament of Oxford to trying to make sure this trial was successfully completed. So there was enormous commitment of the Oxford cardiologists and surgeons to take part in the trial. I did withdraw my authorship from the final publication over interpretation of the data. Now, I would like to stress, because this has often been misinterpreted, there was no attempt in the EXCEL trial to manipulate or distort the data that was actually presented. However, there was a failure to present protocol-specified data that was vitally important to the true interpretation of the EXCEL trial. If you look at first the EXCEL trial and what happened as a statistical trick, if you look at the New England Journal of Medicine paper at 3 years in which I was an author, this used a non-inferiority design with an upper margin of 4.2%. However, at 5 years, non-inferiority was changed to superiority without any discussion or explanation, so that the primary outcome at 5 years on superiority now had an upper margin of 6.5%, that allowed them to say there was still no difference in outcome, whereas if the original non-inferiority design had been maintained, PCI would have been rejected on a statistical basis as having been clearly inferior to CABG. And you have to look at this and ask, were the statisticians on the paper asleep? And why did the New England Journal of Medicine not detect this? The second concern, and I think probably the most important concern, was the clinical reality of what EXCEL showed. If you look at 5 years at death from any cause, you can see that it is statistically significantly in favour of bypass grafting. And if you look at the shape of the survival curves, you can see that there is an acceleration in survival in favour of CABG at 5 years, suggesting that if you followed these patients up even longer, that survival benefit would be even greater. If you bear in mind, as I said, these were relatively young patients, 66 years, with low and intermediate severity disease. At 5 years, PCI had a 38% increase in death and an accelerating death rate accompanied by changes in non-procedural MI and repeat revascularization. Despite that data, the authors concluded in patients with left main disease of lower intermediate anatomical complexity, there was no significant difference between PCI and CABG with respect to the rate of the composite outcome of death, stroke, or MI at 5 years. Now, if you read that conclusion before you looked at the data, this is what I said in my second slide. Always look at data before you read the text. If you look at the primary and secondary outcomes over the 3 time periods, at 0 to 3 days, we can see no difference between PCI and CABG for death, stroke, revascularization, but CABG had a higher incidence of myocardial infarction using a new, untried, untested biochemical definition. At 30 days to 1 year, there was no difference in death, stroke, or MI, but by now, the incidence of repeat revascularization was higher with PCI. And at 1 to 5 years, there was a large increase in the PCI group in death, MI, and repeat revascularization, but no difference in stroke. Despite this data, the conclusion of the authors was there was no difference between these treatments. Now, there's been major discussion about the definition of myocardial infarction in the EXCEL trial, and I'm not going to go through all of this slide because there's too much information, but I want you to concentrate on the first box to understand what the controversy is. The EXCEL protocol repeatedly specified it would report both a new biochemical definition of MI, the so-called SKY definition, that was introduced by Dr. Stone into the trial, but was a definition that had been never tried or tested before. But EXCEL also repeatedly committed to reporting the standard UDMI, universal definition of MI. And that was very important for 2 reasons. By reporting the UDMI, it would have allowed comparison in the EXCEL trial of the new definition with the standard definition. But by reporting the UDMI, it would also allow us to have compared myocardial infarction data in the EXCEL trial with other studies. But at the end of the day, only the new definition was reported, and this was used to drive the composite endpoint, and I will show you why that was very dangerous. The only place to date the universal definition of MI data was actually presented on the BBC, and it showed a far higher rate of MI in the PCI group. And for the record, I did not send that data to the BBC because I don't have access to that data. Why is all of this important? This is a paper we published in Circulation looking at myocardial revascularization trials. And Dr. Dayan already showed the study by Co. On the left cartoon, showing if you compare the second universal definition of MI to the third universal definition, and then the SKY definition used in EXCEL, you can see that with PCI in blue, the incidence of MI falls by about a factor of 3, but the incidence of MI by CABG, only defined on biochemical criteria, now increases by a factor of almost 6-fold. So we concluded a change in the definition of periprocedural MI from the original EXCEL trial protocol affected the composite primary endpoint and the non-inferiority result of the EXCEL study at 3 years. Now, this is even more surprising if you look at this major paper published in JACC by 2 of the key authors of the EXCEL trial, Dr. Pocock, who was the lead statistician for the trial, and Dr. Stone, the senior principal investigator, because they talked about the importance of selecting components from the composite primary endpoint. And they asked, in 2015, what endpoints should contribute to the composite primary endpoint? The usual composite is CV, death, MI, and stroke. Some are tempted to add in extra components. This boosts the number of events, but dilutes the effect and meaning of the composite. For instance, the most frequent and often least clinically relevant component tends to be the driver of event rates, enzymatic MIs. So despite that warning that we should not be using enzymatic MIs for the primary endpoint, that is precisely what the authors then did in EXCEL and used it to drive the primary endpoint. And Dr. Dayan also showed this slide from Dr. Stone, When he was arguing for revascularization in the ISCHEMIA trial, he now changed from what he had done in the Excel trial and now said non-procedural MIs are more strongly related to CV death than procedural MIs. Yet in Excel, he had done exactly the opposite. He'd used the primary outcome definition driven by procedural MI rather than non-procedural MI, which was higher in the PCI group. So if you re-examine Excel, as Mario Godino did, and exclude peri-procedural MI, if you look at the original analysis, which claimed to show no difference between PCI and CABG, and then you remove peri-procedural MI, you see that CABG becomes a clear winner for the composite endpoint and for the specific endpoints of death and non-procedural myocardial infarction. And also, but not mentioned here, a highly significant reduction in repeat revascularization. And I think the fourth concern of the Excel trial was the refusal to share data. I show you the statement published in the New England Journal, the data sharing statement, and the question was, will the data collected for your study be made available to other authors? And the answer was no. Now, this is extremely surprising in any study today for any authors to refuse to share data. And what is actually very paradoxical and ironic is Dr. Stone and the Excel authors have published numerous meta-analyses themselves using data from other people's studies. So you have to ask, why would they be so insistent that no one else can see the data in the Excel trial? I'll turn quickly to Noble, because Noble was the other large trial that compared PCI versus CABG. I've highlighted some key differences between Noble in blue and Excel in red. And you can see that the mean age was similar, 66 years, but the syntax score in Noble was 22 versus 26 in Excel. And 15% of patients in Noble had diabetes versus 30% in Excel. So Excel patients had a higher instance of diabetes and more severe coronary disease. If you look at Noble at 5 years, they did not find the difference in all-cause mortality, but similar to Excel, they found a rapidly diverging acceleration in terms of non-procedural myocardial infarction and repeat revascularization in the PCI group. What did the Noble investigators conclude? They said they had reached the predefined number of endpoints, so their trial was conclusive. PCI remained inferior to CABG in 5-year MACE. CABG was superior to PCI, and they point out, crucially, also in the group with the lowest syntax score. So even in patients with syntax scores below 23, they saw a benefit of CABG. All-cause mortality was similar for PCI and CABG. And finally, PCI resulted in higher rates of non-procedural MI and repeat revascularization. So what do we take from Excel today, and what can we believe to be true? Well, it depends what evidence you want to follow. The European Heart Journal published this meta-analysis comparing drug-eluting stents versus CABG that was based on 5 randomized trials, and it concluded there was no benefit for CABG either in terms of mortality or individual endpoints of cardiac death, stroke, or MI. But as Dr. Dayan pointed out, if you look at the procedural MI data in the paper, it was actually higher. I'm sorry, the non-procedural MI data, it was in fact higher in the PCI group. But what's striking about this paper, it was received on the 2nd of February 2020. It was revised 8 days later, and the revision was then accepted 3 days later. So 11 days from receiving the paper to revising it and final acceptance. And I've never seen that before with a manuscript. But what did this meta-analysis really shows? Well, it's what I would call meta-analysis magic, because it took 4 smaller, weaker trials and added to the largest, most definitive trial, and then waited until the mortality benefit of the Excel trial had now disappeared. But if you want a much more realistic and harder analysis of this data, is by Dr. James Brophy in JAMA Internal Medicine. when he did a Bayesian analysis, the most scientific, accurate way of looking at data from individual trials. And he concluded that the data specifically suggested, whether based on Excel results alone or on the totality of available evidence, that PCI was associated with inferior long-term results for all events, including mortality, compared with CABG for patients with left main coronary artery disease. So I'm going to say today that as we look at treatment of coronary artery disease, and bearing in mind what I said, that the vast majority of coronary disease that needs revascularization by CABG is multi-vessel disease with or without left main disease. For multi-vessel disease and with disease without left main, CABG is a clear winner for all patients, and especially in those with diabetes. For left main, CABG is a clear winner for those with more severe disease, syntax scores above 32. But the two largest and most definitive trials of left main in patients with low and intermediate severity disease have shown that CABG is superior to PCI, including for mortality in the XL trial and for non-procedural MI and repeat revascularization in both XL and Noble. So my personal view based on this data is that current data suggests that there should be a more cautious approach to the use of stents in patients with low or intermediate severity disease, and particularly in younger patients with an anticipated long life expectancy. And in my final slide, I'll show this slide that I've been showing for literally 16, 17 years. There are three reasons why CABG is a survival benefit over PCI. As Dr. Gomes showed, it's got a lot to do with the protective effect of placing bypass grafts to the mid-coronary vessel. It's because the mammary artery elutes nitric oxide into the coronary circulation, which reduces further disease progression. And it's because for many patients, PCI means incomplete revascularization. So on that point, I'm going to conclude my talk. I'd like to thank the Brazilian Society, and Rui in particular, for the invitation to give this presentation. I'd like to thank you, the audience, for your attention. Thank you.
Thank you very much, David. I'll ask the debater, Fernando Moraes, to start the debating. We have some questions from the audience. I'll ask them afterwards.
Okay.
Rui, thank you. First of all, I'd like to thank the Society for the invitation to be taking part in this important webinar. We've so distinguished the surgeons and colleagues talking about a very, very debatable subject, that is coronary and mainly in patients with left main disease. I would start addressing my question to Dr. Victor that raised an important topic about the evidence-based, and he raised an important topic about the use of the medications in this group of patients. He said that in most of the trials, there were a discrepancy between the groups that submitted to PCI. In most of the cases, they use more medications that could be affecting the outcome of these patients. So, Victor, I would like to ask you if in the surgical group of patients, if the use of bilateral mammary arteries, or if the use of a number of arterial grafts would impact in the outcome of these patients. What's your opinion about this topic, the use of more arterial grafts, looking for the long-term outcome in these patients? That was talked, was raised this point by David and Walter, the importance of looking in long-term outcome, mainly in young patients.
Thank you, Fernando, for the question. And I think that's an important topic. And as a matter of fact, I can rely my answer on a recent paper that was published. I don't remember the author nor the journal. I think it was in the Journal of Thoracic and Cardiovascular Surgery, which addressed specifically that issue. It addressed long-term outcomes in patients with not only bilateral internal mammary artery revascularization, but arterial revascularization, and it compared the outcomes based on the number of distal grafts using arterial conduits. And the result was that the higher the number, I don't know if it was from Puskas or the main author, I don't remember, but the conclusion was that the higher the number of distal arterial grafts, the better the survival. Obviously, that issue loses power as you increase the number of arterial distal grafts, because the number of patients that are subjected to that higher number of distal arterial grafts, let's say 4 or 5 distal arterial grafts, is lower, and therefore the confidence interval is much higher, and therefore in order to find the difference is much difficult. But if you use, for example, 3 distal arterial grafts, which is, let's say, like a very standard issue, you find that the higher the number of distal arterial grafts, the higher the survival. So I guess that's an issue that, of course, needs to be verified perhaps with us. So, and I don't know what about the ART trial, which I think it's the only randomized control trial using bilateral arterial grafts. So maybe a future analysis, or maybe Dr. Taggart has some further information regarding what do we see in a trial whose main objective is total arterial bilateral arterial vascularization.
Could I also ask David to talk about this topic and say what's your impression, David, about the use of medication and comparing to the use of arterial graft? Do you think the patients that use both bilateral arterial grafts, would they need less medications once you defend the production of nitric oxide, would protect the layer of the coronary grafts beyond the anastomosis?
So, Fernando, Victor, is a great question. We've all seen redo angiograms where you still have the patent IMA to the LAD and everything else is gone. And yet when you look at the territory distal to that IMA, it still looks absolutely perfect. So I genuinely believe nitric oxide protects the coronary circulation. Tom Lucier showed that in the New England Journal of Medicine 3 decades ago. I think with regards to optimal medical therapy, we published a very good paper in JACC looking at all the trials of PCI versus CABG. We looked at all the levels of medication to the PCI and CABG patients, and it showed very, very clearly that CABG patients had substantially inferior medical therapy, and that if you looked at those patients, they were more likely to die than the CABG patients who had very good medical therapy. So I think the way I would answer it is, I think if you've got 3 patent arterial grafts, you are more likely to have a better preserved coronary circulation than someone with 1 arterial graft and 2 vein grafts. And I think the real importance of medical therapy in patients with vein grafts is not only to try and reduce disease progression in the vein graft, but at the same time to add benefit in terms of protection to the coronary circulation. So to sum it all up, I would say everyone should be in medical therapy, but the more vein grafts you've used, the more important the medical therapy is.
Okay, thank you. And another point that I'd like to hear from you is regarding these trials comparing PCI versus CABG. Why didn't you advocate as one of the PIs in the Excel trial in the beginning to the group of surgeons, to the patients that would go to the arm of CABG, to use more arterial grafts. Do you think it would impact in the long-term follow-up or in the difference between the results of these both arms?
So again, it's a great question, Fernando, because we discussed this at length. And the view I took was, both from what I had read and my own personal experience, if you've got a patient with left main, which is ostial or mid-shaft, but not distal bifurcation, and without a lot of additional proximal coronary disease, my concern in these patients, because I do them off pump, is when you open the LAD, the blood hits the roof. And I think so it's consistent with what we saw in the left main patients in syntax with scores below 32. CABG was not better than PCI. And I think reading that data, the way I interpreted it was that if you've got left main, unless it's a severe distal left main, or there is additional significant proximal coronary artery disease, I think arterial grafts are more susceptible to competitive flow. So if we had the patient with significant left main plus 3 vessel coronary disease, then of course we try to encourage people to use arterial grafts, but not for the less severe forms.
Perfect. And the next question I would address to Professor Walter Gomes. Walter, once we have these results of the X trial showing that PCI is not inferior, although there was a lot of polemics, and what do you think it is the nowadays practice in patients with left main disease? Do you think the XL trial has changed the practice in your unit, in your country? What's your opinion about that?
I think the impact of all of these trials, mainly the XL and all of this controversy about the XL, they have pushed the cardiologists to the surgeon's side. They are all seeing all of this controversy, and they are siding with the surgeons. It means, based in their experience, they think the best treatment for left main is also surgery. Very rarely, and I live in the middle of among many cardiologists, very rarely you see a cardiologist indicating a PCI for a left main. That's true for all around the hospitals we see in São Paulo and also in the country. And I think most of these merits are for David Taggart, because he raised all of this suspicion about the fake data in the Excel. And many authors all over the world are supporting the David assumption that something is wrong with Excel. We need to see what's going on for the near future regarding the reanalysis of the Excel trial by the New England Journal of Medicine, because all the guidelines will be based in the conclusion of the Excel. If they don't change the conclusion of the Excel, it's going to be a problem for the guidelines. But they have to change it, because there is so many skills, so many evidence of manipulation of the data. It's not possible to go on this way in the conclusion of the New England.
Now I would address my question to Professor Bráulio. As we know, one of the criteria to not select patients in the ischemia trial was patients with supposed to have a left main disease. I'd like to hear what's your opinion once I suppose you're a cardiologist, a physician, about the Excel trial, would you recommend, would you send patients to do a PCI, or do you think these patients would be better treated if they were sent to surgery? What's your opinion about that?
Okay, thank you for the question. I am very critical since the beginning for the Excel trial. I have commented with Walter about the way they have analyzed the data, because as Dr. David commented already, they make some magic in analyzing the data. Yeah, I used to teach my student and colleague that you have to look at the data. Forget the opinion of the author until you have a little confidence about how the quality of the data. And the data of the Excel is not believable in my viewpoint. It's not believable. I think they don't change 1 millimeter about my idea that the best way to approach stem heart disease is by CABG, if you have to do something. I think that is very difficult to change in short period of time because of what happened with the Excel. The Excel is, I agree totally with the interpretation of Dr. David. Humbly, I have made the same assumption when I read the test, because they divide the same way they did with the ISCHEMIA Trial. Because the analysis did fulfill what they expect, they change the analysis for non-parametric interpretation of the data. That's not possible when you make some assumption. It's like you change the threshold of what you think is positive or negative, as Dr. David told. For example, I don't accept that you design one clinical trial and inferior style, then you move it for superior style. That's not the way that you have to do it, because the major point when you do some research is that you always have a possibility to work with the wrong sample. And that way, you have to be very conservative when you find something that's not expected. Unfortunately, if you find something that's not according to your viewpoint, you have to be humble. You say, probably, I did find what I find. Probably, the population that I expect or the technique that I developed don't fulfill what I expect. Unfortunately, we live not in an ideal world of a clinical study. We live in a modern world when people sometimes put your position ahead of the data. But fortunately, we have good doctors like Dr. David Taggart, Dr. Walter Gomes, that always have respect for the patient, respect for the science, and analyze the data in very confident way. So, in summary, I could say that I did change one iota for the result of the Excel, and I'm very confident that New England in short term has to take care their right position and make a more adequate comment about the analysis of the data, because that will be very good for the science. Because of the way the medical investment, because of the pharmaceutical investment in the medical arena, has done an excellent role, no doubt about that. But unfortunately, we have some deviation in that perspective. That is my viewpoint. Thank you for the question.
Okay, thank you, Bráulio. I'd like now to, I suppose there are a lot of questions from the audience. So, Rui, if you want to ask the questions from the audience.
Well, I have some questions from the audience. First, from Mario Hernandez. He would like to ask Dr. Taggart if you think hybrid revasc is something to do nowadays with this pandemic, with the internal mammary artery to the left coronary artery, and then PCI for the others. What do you think about that, David?
So I think it depends on individual patients. So, for example, if you've got a fit 60-year-old with little in the way of comorbidity, severe coronary disease, with or without diabetes, that patient's going to be best served over the long term by 3 arterial grafts. If it's an 80-year-old who's not so good or a bit frail, then you're much more concerned about what's the least invasive procedure for that patient. And it may be in that, and even in 80-year-olds, even a small thoracotomy can be still quite a traumatic procedure. So I think I would not be against doing hybrid procedures, but I think you've got to base those treatments to the individual patient. In other words, it's not one glove fits all. So you've got to tailor your therapy to the individual patient.
Rui,
Okay, I've got.
may I?
Yeah, you can answer that with the next question also, because it's for you and for David. Mariano Vrancic is asking if why don't you think beta grafting isn't a strategy of choice around the world today?
David, do you want to go first?
No, please, Walter, you go first.
First, I would like to go over the issue of hybrid revascularization. I think hybrid revascularization is a dead concept, because why we do a revascularization procedure? Mainly with two goals. First one, decrease the risk of myocardial infarction, and then improve long-term survival, and also improving quality of life. Based on the findings of the ischemia, the courage, the body 2D, we see no additional benefits from PCI with coverage. If you do a memory to LID, what a stenting of the right coronary artery disease or even the circumflex can provide of additional benefits to the patients? Nothing. And so I think hybrid revascularization is a dead procedure that has no reason to exist anymore, because can't provide any additional benefits to the patient beyond surgical revascularization. Now, replying to the second question about why beta grafting is not widespread in the world. There is several problems related to beta grafting. First one is take longer in the operating room for doing beta grafting. It's not always true, because in our hospital, we take down buff memory faster than we take two pieces of vein. So, mainly when the most experienced people take down the memory, the resident is still finishing the first segment of the vein for the operation. So, but in the United States, that's a problem. The other problem is related to the increased incidence of external complications. Not for us, but in the United States, it's money. It's related to for-profit procedures. So the surgeon in the United States, they can't do this procedure because if this patient has some complication, mainly external complication after the operation, this complication is not reimbursed for the third-party payer for the hospital. So it's a loss for the hospital. So it has several implications why BIMA graft is not a widespread procedure and the usage is too low around the world. I think it's improving, step by step is improving, but it's still low for what should be.
So I largely agree with what Walter has said. The only other thing I think I would think many surgeons consider that they are only judged on very short-term outcomes, mortality, morbidity, short-term morbidity, and not on potential benefits over the long term. So there is no incentive for the surgeon to do an operation, which is technically a bit more challenging than using a mammary and vein grafts. That's a fact. I think the other paradox of this is that many people use the, well, if you look at the ARC trial, as Walter showed, on the intention to treat analysis, there was no difference in mortality at 10 years. But 40% of patients in the ARC trial got a different treatment from what they were initially proposed to have. And if you do the as treated analysis and look at what happened to patients who did get 2 arterial grafts, they had a far better survival at 10 years than those who do a single arterial graft. So I guess the ARC trial, if you're against doing arterial grafts, you will follow the intention to treat analysis, despite the number of patients who crossed over. And if you're in favour of arterial grafts, you can look at, well, what happened to the patients who got 2 arterial grafts? And they had significantly better survival at 10 years.
I asked Dr. Taggart, what happened to the patients in the 80s, 70s, and 80s have received bilateral grafts? Were they survival that much better than the ones that have not received it?
So it's a very good question, and literally that analysis, the 10-year outcomes of patients above and below 70, we are currently doing that analysis just now. But one of the things I think, and Dr. Gomes alluded to this, people say, is there a cutoff for the age of the patient for the use of bilateral ITA grafts? And the answer is absolutely not. Because you use ITA grafts in younger patients looking for the survival benefit. But the fantastic thing about bilateral ITA grafts in the elderly is it allows you to revascularize the heart without touching the aorta. Now, almost 16% of our patients are now over 80. And if you say to an 80-year-old, you might die from your cabbage operation, they will accept that. If you tell them they might end up with a stroke, they are terrified. So the beauty, and it's one of my favorite operations, is an 80-year-old with a very tight calcified complex distal left main, where you simply, who is not suitable for PCI, where you simply do a median sternotomy, take both skeletonized mammary arteries, sew them together, revascularize the LAD plus the most important vessel on the lateral wall, and close the chest. And the risk of that patient dying or having a stroke is exceedingly low if that's done with a true no-touch aortic technique. So the beauty of mammary arteries is I think they have different things to offer the patient at different ages.
I have another question for you or for the others. Is there any role of the no-touch vein grafts in improvement with the use of no-touch vein grafts?
So, does Walter, I mean, I'm happy to answer this as well, but let's ask one of the other surgeons what they feel.
Walter, what's your opinion about it?
Victor?
Or Dr. Dayan?
Thank you. So, no, here I am. Okay, so there is a very interesting trial, randomized control trial from, I think, from Korea, a Korean group of surgeons that used the no-touch vein technique and used that vein as a white graft from the Lima, and they show pretty good results, right? So I don't know, the permeability is almost very high. I got mistaken, they showed that the permeability was almost similar to another arterial graft. So, but that's a single center experience, not a single center, but a single investigator group experience. I'm not very sure if that's something to be extrapolated right now to cardiac surgeons worldwide, but at least in that study, they showed some promising results. I don't know what's the opinion of the rest regarding that.
So I would say, I think the evidence for the no-touch technique for vein grafts is exceedingly high. I think Dr. Domingos Souza, who's been doing this in Ribeiro in Sweden for 16, 17 years, has produced outstanding results. And as Victor has just said, if you look at the data from Korea by Dr. Ki-Bong Kim's group, it's fantastic data. I mean, it's truly spectacular. one of the problems we have in the West now would be almost everyone in my country, when they're taking vein grafts, does them endoscopically. And to go back to making full incisions in the leg would not be terribly easy. I think that becomes especially true because there is no doubt that these endoscopy, the no-touch technique means you're left with much more leg morbidity. And if it's an obese diabetic patient, you can get terrible wound problems with it. So 40%, in most people's practice now, 40% of patients are diabetes with obesity in the West. So I think the quick answer to your question is yes. Is there evidence that they have superb patency compared to other vein grafts? I think the data is very convincing, but unfortunately, there's a price to pay for doing that. So I don't know where this will eventually settle, but I certainly know in our country now, if we would meet a lot of resistance to doing large open leg wounds because the healing of the endoscopic vein harvest is fantastic.
I have a question for the three surgeons, Victor, David, and Walter. We were discussing for a long time that multiple arterial grafts are much better than saphenous veins. But we see not only, like Walter said, in the United States because of problems, but in Europe and also in South America, this is not the operation that most surgeons will do. This is a minority. For example, the STS, Mario Gaudino has, as it was said by José Antonio Heredia Delgado, that only 40% of the patients had multiple arterial grafts. So why are we not doing the best operation for our patients, and we're just grafting them and not thinking about the, let's say, the long-term survival of these patients? Let's start with Victor.
Thank you. So I think we surgeons have been very rooted with the concept of the 65-year-old barrier. So patients above 65-year-old, in our country at least, it's very difficult to be considered for a BIMA, which is what we do most here in my country. And so, regarding my personal experience, and we are generally also more exquisite and very specific regarding the patients with diabetes, for example, and we guide ourselves a lot on glycosylated hemoglobin levels. Perhaps this is a very good opportunity to see what's the best cutoff level. So patients which have uncontrolled diabetes, we do not do BIMA revascularization. We may use, of course, radial artery, but not BIMA. And further on, we prefer to use BIMA, which is, as I said, the technique most used in our country, on tight lesions due to risk for competitive flow, as Dr. David Taggart previously said. So maybe that's several barriers which may take the percentage of arterial vascularization quite low in our area, in our country, and not being so much more aggressive. And as a matter of fact, after the results from the ART trial, several surgeons lost a little bit of enthusiasm on the arterial vascularization for patients younger than 65 years old, right? So maybe that issues are in the head of several of our surgeons in our region.
Can we have Walter's opinion?
Total arterial revascularization is a tricky concept because there's some situations where vein graft is the best option. As I used to say all the time in our hospitals, what's the best graft to the LAD is the left memory. What's the best graft to OM is the right memory. But what's the best graft for the right coronary artery if the blocker is less than 90%? It's a vein graft. because the results with radial is not good. The radial is the appropriate graft for stenosis greater than 90%. Otherwise, the long-term results are not good. So there's some situations where the arterial graft is not the best option for the patient, like in this situation. And that's what we do in the day-by-day practice. What do? We do bilateral internal mammary artery grafting in more than 80% of the patients. But usually the graft going to the PD, the PDA, the most of the time is a vein, and we attach this vein or to the as a Y graft to the left or to the right the right memory. Depends. We used to do the top end at the non-LID memory. Also, we avoid putting the Y graft in the memory, revascularizing the LID, not to endanger the graft to the LID. So that's what we do in our day-by-day practice.
Can I ask you a question to the surgeons, to Victor and to David? Walter, I know his answer. What's been the average number of cabs being performed in UK, for instance, in Uruguay, or here in Brazil? Do you think they are decreasing the numbers? Of course, we are taking, I mean, not at this period, as this pandemic, I mean, because of the COVID.
Sure.
What's the scenario in your places?
Okay, so in Uruguay, let's say that in the last couple of 5 years, there was a persistent decrease. That let's say that in the last couple of years, 1-2 years, it got just added. So I think there was, I guess our situation is much similar to what we have seen in other countries, but I think nowadays it's not continuing to decrease as we saw that like 5 or 10 years ago. So actually we are in a plateau, which I guess with longer term follow-up of data from these randomized control studies, we may get, for example, a steady increase in the number of procedures, which I don't think so, but it's my expectation.
So we have, in the last kind of year, in the last year or so, we've actually seen an increase of about 8% in cabbage operations in the UK, because I think a lot of cardiologists have become less sure about PCI, certainly in patients with multivessel disease, and they have also been affected by the results of the left main trial, Excel, in that they are worried about what that data shows, and they don't have the same confidence before that they had to say, oh, we can stent everyone just the same. So we're seeing it going in the cabbage increasing again. Just to very briefly to go back and address the question of why there's so few arterial grafts being done, I think it also raises the issue of it is time now to have some surgeons trained as specialists in coronary artery bypass grafting. Everyone accepts we have specialists for mitral valve disease, aortic valve disease, endocarditis, large aortic disease. And yet there's still a feeling out there everyone can do a mammary in 2 vein grafts on bypass for everyone. Now, a mammary and 2 veins on bypass, 2 vein grafts done on bypass is a great operation when it's used appropriately for the right patient. But it is definitely not the right operation for every patient. And I would certainly, knowing what I know about coronary disease, if I did need coronary revascularization, would I be happy to say, well, I'll have a mammary in 2 vein grafts? Now, Walter said that maybe sometimes that's right, of course, but by and large, I would say no. But equally so, I would not go to a surgeon who said, well, I don't normally use 3 arterial grafts, but I'll try it on you. I would say no. I would go to someone who does that all the time because, you know, it's like Roger Federer doesn't go out and play tennis once a week. He plays every day. And the same for coronary surgery. It's actually the most technically demanding part of adult cardiac surgery because the margin for error for coronary surgery is less than 0.5 millimeter. For a valve, it's 2 or 3, maybe 4 millimeters. So doing coronary surgery demands a higher level of proprioceptive skills and training, etc., etc. But so, and people say to me, well, should every surgeon have to be able to do 3 arterial grafts? And my answer is no. But every unit should have 1 or 2 surgeons who can do that and do it off pump. So that when they do have that genuine, because the other thing people say to me is they ask me about off-pump surgery and then they say to me, I reserve off-pump surgery for my high-risk cases. I say, well, you're mad. Because the last thing you want to do when you've got a high-risk case is to change your technique. Because if it's a high-risk case, you've already got additional stress. So you don't want to start saying for the high-risk case, I'm going to do something different that I don't usually do. This is madness. So I don't think every surgeon needs to be able to do 3 arterial grafts off pump. But if you're a unit that offers serious coronary surgery, you should have 1 or 2 surgeons trained in that procedure to a high level. In the same way, you would not say, well, every patient who comes here with mitral valve disease gets a mitral valve replacement. That's not, you know. So I think what it's showing is there needs to be some increasing level of recognition and specialization in coronary surgery. And remember, CABG still accounts for almost 60% of all adult cardiac surgery. So it is still the most relevant operation. And, you know, I used to go to conferences with AATS, EACTS, STS, and I could sit all day listening to the most difficult, complex operations that I was never going to do and that most people in the room would never do. And yet in terms of what our bread and butter, coronary bypass surgery, nothing. So I think we as surgeons need to kind of reevaluate what we're doing. And I would emphasize, I'm not saying everyone's got to be able to do 3 arterial grafts off pump, but every serious unit should have 1 or 2 surgeons who can do that operation well.
Thank you, David. I think it's almost 1:30 in the morning. Oh. And someone has got an outpatients clinic. So I'll ask Dr. Murat to end this webinar, and I thank you all for all your presentations. I hope to see you personally, and keep safe, all of you.
Thank you.
Now, I think first all the panelists, this was a superb evening. And we have run how to treat, how to manage coronary artery ischemia trial with Dr. Bráulio. We have seen the scientific evidence of making the use of scientific evidence in practice by Dr. Dayan. Dr. Gomes gave us hit on bilateral grafting, ITA grafting, as a winning strategy, and David Taggart gave us an excellent comprehension of the Excel trial.
Thank you.
Problems that were involved. I thank you all. And Fernando Moraes give us asked questions that were very pertinent to all the participants. I'd like you all to have a very good evening and good night for all. Thank you very much.
Thank you very much, and thank you for the invitation to join. It was an excellent session.
Thank you very much,
David. Thank you
for this honor.
Thank you.
Goodbye.
Thank you all.
Bye-bye.
Goodbye, David.
Thank you very much. Bye.
Bye.
Gracias.
Gracias.
Bye a todos.
Okay.